Hi, everyone. My name is Jen Braun, and I direct the AHA Team Training Program here at the American Hospital Association. Welcome to our April webinar on problems, possibilities, and people using human-centered design to create and scale change for teams. I'm really looking forward to this webinar because human-centered design is really the cornerstone of our TeamSTEPPS courses, in which our partners here at DoTank, who are presenting the webinar, helped us design a couple years ago. So you'll get to learn much more from them about the benefits of human-centered design here in a moment, and I'll introduce them here in a second. But before I do so, just a few rules of engagement. So you can access audio by either listening in through your computer speakers or through your phone. If you're having issues, you should be able to access the toolbar at the bottom to switch to either the phone audio or the computer audio, depending on what you need. Please note that everyone is in a listen-only mode. So if you have questions, feel free to chat them in or want to discuss with others in the chat. We can get that going. If you have questions that are technical or logistical, we'll answer that in a moment. But if it's for our speakers, we'll save that for the end, should time allow. So moving on to continuing education credit. So we are happy to offer free CEs for our webinars. So in order to claim your CE credit, you must create a Duke OneLink account. Duke Health helps us provide our continuing education credit. And so this is a one-time only setup. And so Kara will chat in those instructions, and you should also be able to refer to them in the email that you received either this morning or in the confirmation once you registered. Following the webinar today, you're going to text ZAHTAV to the number you see there. And so we'll share this at the end as well. Those instructions have also been included in the chat. But in terms of some upcoming events that we have, registration's open for those 2-day TeamSTEPPS Master Training courses for the first half of the year. So if you're interested in registering for one of our courses, please note that we do encourage teams to attend, and we have a team discount, so you can visit our website to learn more. And so in addition to our in-person course, we also have registration open for our virtual Master Training course that begins this fall in September. We also have registration for our next free webinar on May 14th, which focuses on workforce well-being, which will be presented by the Chief Wellness Officer from Mount Sinai, which would be a really interesting session. But basically, if you like what you see here today with some of the human-centered design components, I really encourage you to look into our TeamSTEPPS Master Training courses if you've never been to one before, because we really bring in those elements to support the both strategic and tactical implementation plans that participants walk away with. And then finally, in terms of our custom advisory services, so if you or your organization is interested in more one-on-one support, we can provide either a customized TeamSTEPPS course all the way up to a comprehensive TeamSTEPPS programming where we come to you. So if you're interested or want to learn more, you can sign up for a one-on-one info session with our team training clinical program lead, who can share more information with you. And so enough of me and some of these housekeeping announcements. So as I mentioned, the team that we work with at DoTank, we have worked incredibly hard with us in recent years to enhance our TeamSTEPPS curriculum to include those human-centered design elements, which has really transformed how teams can help create and scale change, whether the change is related to TeamSTEPPS or another quality improvement or patient safety initiative. So I'm really pleased to turn it over to our DoTank team that includes Matt, Leslie, and Adam. So guys, I'll turn it over to you.
All right, thanks, Jen. So, yeah, you got three of us today, folks. So we're really happy to be here. And my name's Matt. I'm a founding partner and designer with DoTank, and I'm joined by Adam and Leslie, who are your real subject matter experts here. Collectively, they've got so much experience working, with systems and associations and hospitals and care providers and all kinds of great stuff. So today, we're really excited to share a few things. So just at a high level. As Jen mentioned, we've worked with the AHA for years. So when we opened our Chicago office, it was a block and a half from the AHA headquarters on Wacker Drive. So it's been an amazing partnership over the years, including just, with Jen's team, the Advancing Care Conference, and all these cool design canvases that are integrated in the TeamSTEPPS training. So it's been a wonderful partnership. But about half our teams in the United States and about half of us are in Scotland, and most of our work's in healthcare. So we're really excited to join you here today. So buckle up. We got a lot for you. So if you took a peek at the the deck that Kara sent in advance, you'll see that we got a fair bit of content. So I just want to tell you that in advance. Keep your notebooks handy. Highlight any things that really resonate and stick with you. We're going to take you through a basically a blend of some case studies. We're going to highlight a few specific tools that you can use with your teams, and then give you some kind of tips and tricks and some theory around how to best kind of shepherd change. So it'll be a blend of those three things. Leslie, Adam, and I are going to share the baton and do it kind of as a relay. So as you know, Jen kind of mentioned at the beginning, you can put any comments or questions you have in the chat. But we're always open to chat about this stuff. So if you have questions after the event or something strikes your mind at any point in time, we'll share our email addresses, and we're always kind of game for that. So that's kind of our goal here, is to share a lot of stuff, but hopefully spark a few ideas, give you a few tools, give you some inspiration that you can actually come and use with your team. So with that, I'm going to kick it over to Adam to get us going on the content.
Awesome. Thanks so much, Matt. Yes, the carousel begins. So I'm going to lead us off by talking a little bit about human-centered design and our philosophy. And really, this slide captures the mantra of our healthcare team. We feel that if any field should be human-centered, it is healthcare. And so we're helping teams at that intersection of quality, equity, and innovation design better systems, better outcomes for your community members. And I know from our time in the field, we hear so often about patient-centric care, stakeholder-centric care, and we really take that into account. So every group that we're working with, whether it's a hospital, community-based organization, FQ, or state hospital association, we're really focused on those stakeholders and on creating a sense of empathy and understanding from everybody around the table. Too often we have clinical or operational or strategic teams who want to just jump straight to the solutions and straight to the problems before they canvas deeply those stakeholders who are engaged and who are going to be affected by the quality improvement work you're doing, or the strategy planning, or the community partnerships you're building. So we really ground all of our work in that foundation of empathy and understanding. We embrace these four principles really of human-centered design that make up our operational philosophy. So design thinking, really rooted in empathy. Visual thinking, you're going to see a lot of examples today of visual thinking canvases, which is kind of our tool that it's our hammer in our tool, but we've got a lot of tools, but the visual canvases are kind of our hammer. So you're going to see a lot of examples of those and how we integrate these innovative principles and move at pace with these canvases to help folks streamline their thinking and their strategy together. So a lot of our work is grounded in this kind of double diamond philosophy. Leslie next is going to tee up to you our own human-centered design methodology that we've embraced for healthcare, which is inclusive of opportunity validation, concept development, and value creation. But this double diamond here is kind of the root of that philosophy. Again, teams too often dive to that middle section of solution ideation and they just want to get solving the problem. We encourage teams to embrace these early sessions of the human-centered design phase around problem exploration and problem definition before we jump to solutions, prototyping, and scale. So high level, it's that shift from product-centric work into stakeholder-centric work before we get to the outcomes that we want to achieve with folks. So that's a high-level view of our philosophy that you'll see and feel as this progresses. But let me kick it over to you, Leslie, to talk a little bit about the application.
Yeah, no, thanks so much for that. And so if you could go to the next slide. Most of us probably recognize this quote from Albert Einstein, which is a really good one. And it really speaks to what Adam had mentioned a few moments ago, particularly for complex challenges, spending more time thinking about the problem, its multifaceted nature, the tendrils and depths of the root of those problems is really where that magic happens. And once that's deeply understood, solutioning becomes a little bit more straightforward. And so this Einstein quote very much aligns with that double diamond that Adam just referenced. But the second piece of this, which is actually a quote by, of all things, a somewhat healthcare consultant over the years, is this other piece that's sometimes lost, is that harvesting solution and getting to scale. And I think we've all recognized the fact that we all end up kind of resolving the problem over and over and over again. So this ability to find something that really works, be able to say the nature of what that is and get it generalized so others can benefit from that. If you can spend more time on the problem and more time on the scale, the solutioning in some ways almost becomes de-emphasized. And that might seem a little counterintuitive, but for very complex challenges, that's a really big deal. So these are two truths that we absolutely live by. Next slide. So one of the questions that we always get asked is, what's the difference between business thinking and design thinking? Design thinking is the root of everything that we do, as both Matt and Adam, or sometimes I say Madam, I combine their names, so as Madam, say, is this schematic here, where we're trained and we're paid to solve problems. So it's almost the parlay is the quicker we get to the solution, the better we all do in our careers, the better for our patients and our families. The design thinking piece on the other portion of the slide re-emphasizes that iteration between empathy, multiple solutions, multiple testing, re-understanding, and really that iteration. So if there's one slide to reference when someone asks you, help me understand again the difference between these two, this is a very, very good slide that visualizes what that distinction is. Next slide. So Matt and Adam referenced the fact that we've taken some of the design thinking methodology and developed it for a lot of the work we do, both in healthcare and other complex industries. On the left here, you see a short essay, How High Reliability Began. And that really came out of aviation and nuclear energy because of risk taking and the way to communicate and solve problems. We all know HRO is taken off and it's become a core element of all the work across hospitals and health systems. Next, Adam. So go back, sorry. So we've taken approach something called technology readiness levels, or TRLs, which is a way to talk about the growth and development of novel solutions and applied that to healthcare. So we're not going to go into that in great detail today. If this is something that's interesting, you can certainly follow up with us. But we've basically taken the 9-scale framework that's part of technology readiness levels and brought that into a methodology that can be used for both product and service design. So on the next slide, you can see the 3 higher order buckets for what those 1 to 9 steps look like are in this area of opportunity validation, concept development, and value creation. And that's what, for the duration of our webinar, where we're giving specific examples around how this methodology plays out, we're going to dovetail into those 3 particular buckets. So on the next slide, we're going to now move to examples in the field in each of those areas. And Adam's going to kick it off with bucket number 1.
Cool. And I'll do a brief introduction to each section. So the structure for the rest of the time, guys, is I'll give a few kind of tips and thoughts in terms of practice and approach, and then it'll be followed by a case study and some tools. So Adam, yeah, on the next slide, so we'll kind of go through here. It all starts with the people that you're working with. So when you think of a change initiative, right? Human beings, as we all know, are complex beings, and it's challenging to win the hearts and minds of folks, right? Which is ultimately something you have to do if you want sustainable change, right? You can give someone a direction with lots of oversight and some great esprit de corps off the starting line. Maybe people do things for a short while, but if you really want people to sustain the change, they need to really understand it and have a sense of ownership over it. So right from the beginning, just in the problem definition, that's why we're not starting with you built the thing and just change. Change starts with the problem. It starts before you even design the solution. So on the next slides, we'll kind of share a few other things. So thinking about your community and your group right off the bat is critical. So you want to gather the right cast of characters and think broadly. So on the next slide, you'll see that we want to invite people, and this is key, not just to explore the solution, but invite them to explore the problem and the challenge. So when you bring people early on, they're going to have a deeper understanding of the why. So if you can connect folks with the why, when it's time to do the what, it's more likely to work. And another thing that we always encourage folks is before you jump to solution, whether it's the solution itself or the change program, you must start with a strong foundation of understanding your current state. So in the next slide, you'll see there's 3 things that we always tell folks about is understand who you are, what's around you, and where you're going. People skip this step all the time. So who you are, current state, your relative strengths and weaknesses. What are the levers that you can pull to affect the change? What are obstacles you need to overcome? So examine your own corporate culture, the environment that you work in, the industry, the communities in which you work. Really evaluate the strengths and weaknesses because those will be the things that you can either have foresight around or you can leverage going forward. And then the vision is the why, for what end, for what purpose. So what's amazing about healthcare is it's a mission-driven industry. So you always have these incredible things to anchor and connect with. And that is a huge asset whenever you're trying to introduce change.
Awesome. So Matt, I think that's me.
Yep.
Yeah. All right. So with that kind of overview and tee up of opportunity validation, I want to talk about one of our first case studies from the field. So as Leslie said, we're going to have 3 of these. I'm going to lean into this one first. It was with our partners in Missouri at the Missouri Hospital Association and the Missouri Perinatal Quality Collaborative. And so I wanted to reference this one because all of the canvases that I'll show you in here and the report itself that we created for the state of Missouri are all public, and y'all can use these tools. So I'm hoping that, I know it's quick, but a little bit of the training of the trainer here with some of these tools to give you a sense of how you might be able to apply them, and also some insights for those of you that are focused on the maternal equity and health space, which we're doing a ton of work in these days. So the burning platform that Missouri came to us with was the need to assess the gaps within their maternity care deserts, wanting to get a sense of what those supports needed were that they could help bring to the table, what the challenges were, where the opportunities were. To a lot of the stuff that Matt talked about before, we really embraced this mission because Missouri was not coming to the table with a set idea of what they wanted to do, but it was like, hey, let's start first and canvass our constituents across the state to get a better sense of where their hopes, fears, and ambitions align. And so we looked at the data first and identified 4 regions within the state, which were the most acute maternal health deserts. And we went to these 4 sites over the course of the summer and fall, had 4 different community forums, consisted of 24 hours of programming combined, over 100 folks engaged. And we came up with a handful of big ideas that the association, the PQC, could then take back and decide on what they wanted to operationalize and align on as a team. So what I'm going to show you next are a bunch of visual canvases and a bit of the process that we went through here using human-centered design principles and visual canvases. And know that all the report that you'll get to take a look at, it really was comprised of Post-it notes. And we always say that every Post-it note is a data point. So we had over 1,700 data points that we collected from those 115 participants across these community forums to create this statewide environmental scanner view. And there were a handful of tools that we used during those community forums. We did 3 main things with this tool set. On the left, we spent the morning in a state of really reflection for the state and for the different regions. What are their enablers? What are their blockers? Where was their current state mindset? Then as the morning progressed and we got into the afternoon, we started to ideate a little bit. And this is the thing about human-centered design too. These phases of opportunity validation, concept development, and value creation, there's some fluidity there, right? So even though we were focused on the end outcome here of opportunity validation, we wanted to get some insights from the key stakeholders across the state of what concepts they might like to see, what programs would they like to see. And we got the most diverse group that we've ever had together. We had nurses, we had hospitals, we had doulas, we had hospital administrators, we had parents, we had school administrators. Everyone from these communities came together, and we got a really rich and unique view of the potential solutions and ideation and the big ideas that they have to put forth to the state. So we'll share this in the chat. It's definitely in the slide deck. But if you want to click on that link, you'll get a view of the holistic state report. And I'm just going to deconstruct it a little bit and show you again the process that we took to get there. And the first morning session, as I talked about, we focused on 2 canvases. These canvases are also available on our website, free for download. Great brainstorming canvases or canvases to use with new groups when you're trying to get a sense of the current state and some of the hopes that they might have down the line. So the sailboat canvas is a simple 2-action framework. What are your enablers? What are your blockers? In Chillicothe and Joplin and these different deserts that we're in, what are the wind in your sails? What are those things pushing you forward? And then what are those big barriers that you're having to deal with as a community, as a region when it comes to maternal health? We then took some time to do a persona canvas. This persona canvas centers at the middle the needs or the wants of a group, and then asks about those negative trends, the headaches, the fears on the left, and then on the right-hand side of the canvas, what those positive trends, opportunities, or hopes are. So really good grounding canvases here. Again, the beautiful outputs. So we used those 2 canvases, which powered these pages in the early portion of the statewide report, giving us a keen sense of what the strengths were, the voice from the field, what those weaknesses were that we would need to keep in mind as we moved forward, and importantly, what the hopes were, where the teams wanted to go across the state, as well as the opportunities that they saw, some of that more lower hanging fruit. So that was a couple hours in the morning using those 2 canvases, having really rich discussion and getting as many perspectives around the table as we could. We then started moving into that ideation space later in the day using the KISS model and the idea matrix. KISS model is a super simple one that you don't even need a canvas to do. It's that 4-action framework, 4 quadrants. Current state is in the middle. So in that circle, we put maternal health in the Southwest region of Missouri. What's going well that we want to keep? What's not going well that we want to improve? What are some things that we want to start that we've been talking about that we have the momentum to move forward on? What are some of those things that we should stop doing that aren't working or that are contributing to the problems? So that canvas right there, we use so often in so many of our engagements because it's a great current state and future state analysis tool for teams to use. So we spent time with the KISS model, and then the idea matrix is a great tool because it helps you really in a democratic way say, hey, there's a bunch of ideas here. Let's vet them and let's see which ones have the most energy, the most resourcing, and that are most aligned and realistic for us to operationalize. So we got a lot of brainstorming with the KISS model canvas, and then we helped whittle it down into a handful of ideas through the idea matrix. And that translated into a really robust picture for us at that statewide view of recommendations for the Missouri Hospital Association, the PQC, as to what our focus is from an idea perspective could be by region and then by state. And then the final part of the day was really focused on that moving from ideation to like planning or action. So we challenged those teams that did the KISS and then had the 5 ideas in the idea matrix to whittle that down to one big idea that they would love to frame out. And so each of the core teams in the regions got to utilize the big idea canvas, which just simply frames out a challenge. What would happen if we were going to tackle that with a program, and what would the ultimate impacts be, supports that we would need, and the risks that we might run into, or some of those barriers if we were to operationalize this big idea. The cool thing about this was, towards the end of this report, you'll see the themes that really rose out from those 4 regions. And these won't be a surprise to many of you in this space, but access to care, workforce development, patient education, empowerment, and collaboration were the 4 themes that we heard loud and clear from the regions and the state of these are the things that we need to be focused on if we're going to enhance maternal health outcomes throughout Missouri. It was really cool too, because then we had a lot more pros from the teams that we gathered as they went through these canvases to get a really prescriptive environmental scan for the state of here's the opportunity and at least where the energy lies with your key stakeholders on the ground. The last thing that I'll highlight here is the need for a marketplace. So we often have teams share out. So it's one thing to collect all that data and to bring it back into a nice polished report, but really giving folks the opportunity to let these canvases breathe and be platforms for discussion. There's so much utility in that. And so we had a robust marketplace. If you're interested in seeing any of those aim statements, the aim statements were translated directly from those big idea canvases. So this was a nice process for us to come back to the state and say, we know you want to move on this subject. here's 21 different, really prescriptive, action-oriented ideas from the most key stakeholders in your state. Let's pick a couple. Let's see what aligns with your policy or advocacy agendas and the resourcing you have. And so this was a really deliberate process of that problem exploration and problem definition over the course of 4 meetings at a statewide level. And that allowed the PQC team to move into a solution ideation and prototyping and refinement and scale phase with ideas from the field, as opposed to ideas of 4 or 6 people at the state association who said, maybe we should do this. So that vignette really just highlights the power that you can do through human-centered design of canvassing folks. And if you have any questions about any of these canvases, again, you'll get access to all of them. And as Matt said earlier, we love linking up with teams and coaching you through how you might operationalize this with a small team if any of these canvases seem to ring a bell. So Matt, I'll kick it over to you and we'll tee up concept development.
Yes, and doubling down on, if you're seeing this like, oh, this is focus grouping, this is research, this isn't change. No, it's change. By inviting people into the problem in the early stage, you start to get the buy-in and the understanding. So I can't stress that enough. Change is not just, oh, we've designed the thing, the solution's ready to go, launch. If you really want it to stick and win the hearts and minds of people, it starts much earlier. So now we're in concept development. So Adam, if you go to the next slide, I'll share kind of 2 quick things and kind of pitch it over to Leslie. So you need to have a kind of, once you're developing the concept and the thought, and Leslie will talk about MVPs and the kind of the different approach to that, but your whole change initiative itself has a business model, right? So on the next slide, you'll see a couple of questions. First, we use a tool called a business model canvas. It is arguably the most famous canvas in the space, designed by Alex Osterwalder in the book Business Model Generation. So if you're into this canvas stuff and design thinking, that one's a legend. But he defines a business model as the rationale for how an organization creates, delivers, and captures value. It doesn't have to be an organization. It can be your department, your service line, the change itself. So you need to think broadly about this. So on the next slide, you'll see some key questions. Who's it for? What's the impact? What's the value proposition? How are you going to reach them and communicate it? Are you going to pin notices on the corkboard in the lobby, put things on your SharePoint, send an email, have the CEO mentioned at the town hall, right? The key is you need to think broadly, not just about the solution, but how it will reach people and create value for them. I think that's the point here. And on the next one, you'll see leveraging the power of validation and testing, and Leslie will talk about this a bit. Again, maybe I'm a bit of a broken record, but it's more touch points with people, right? When you give people the opportunity to contribute to the change, then they'll have a deeper sense of understanding and a deeper sense of ownership. And when you have that, they're more likely to be advocates for it and try to ensure that it works. All right, Leslie will take you much deeper. So over to you, Leslie.
Yeah, next slide, Adam. Thank you. So one of the things this slide is intended to show is a definition of what a minimally viable product, we always put in parentheses, solution. And I'm going to spend a couple minutes teeing that up and contrasting that between that and a prototype. And both are incredibly important, but both have fundamentally different jobs to be done. So when we think about a minimally viable product / solution, it's an initial product that a consumer and a stakeholder can afford, that solves an important enough problem for that target audience. By their using it or purchase of it, they'll get vital feedback, which allows for some iterative improvement. So it's then more applicable to a broader market. It also demonstrates values to others that might ultimately want to invest in it and demonstrate that it has real potential. So this idea of when we get into solution development and you go from idea to prototype to minimally viable product or service, the value, delight, something instrumental needs to happen with that end user, even with that minimally viable or that MVP. Next slide. So definitions do matter. And I've always leaned on this particular schematic to outline that distinction between when you go from a prototype to a minimally viable product or solution to that scaled launch. The prototype is to get feedback only. Many of you have probably been in some type of facility initiative where with cardboard and foam board, you'll mock up a new reception room, elements of a patient room where you use stickies all over the place to give feedback. It's that lowest fidelity, tactile approach to a product or solution that allows you to get some of that early feedback. As I said a moment ago, that minimally viable version, it's the first acceptable launch where some value is delivered to an end user. And then once you have that iterative learning, then you can go to that scaled launch. And the reason, again, that that's important, it's the delight and the value that has to happen at that middle point. Next slide. So here's a schematic that I always like to use that kind of showcases the difference between that, using transportation as that example. In the top example, in both cases, the job to be done is transit. In the top example, the end user isn't happy if they just have tires or just a chassis or just part of a car until it goes. Value doesn't happen until that final spot. Down below, the job to be done is transit. You start with a skateboard, then you go to a scooter, then you go to a bicycle. I'm a Vespa owner, so I love it when you get to the Vespa stage, and then you get to a car. At each stage, the job to be done is transit, but the mode of transit and the complexity of how you get from point A to point B is different. Next slide. So much like Adam shared a toolkit that's really helpful in that problem definition or that opportunity validation phase, you'll see there's a little bit of transitioning from how you ideate until you get into that idea of how promising ideas become really good scalable solutions. So however you do your ideation and get that gallery of options, there's then some need to do some prioritization. We typically use an innovation matrix, which is a very simple 2x2. Depending on your individual job to be done, you can change the labels on the axes in that innovation matrix. I probably 95% of the time use disruption as the vertical axis and ease of execution as the horizontal axis. And part of them, the ideas that you potentially carry forward, depends on the mandate for the job to be done. If you're being asked by an innovation team, kind of a go big or go home, you're going to want things above that line that are more disruptive in nature. If you're part of a shorter term QIO initiative where you need to demonstrate something in the next 3 to 4 months, you probably need evidence from the field from others that it works. Things might be below that line. If you have a little bit more time to play with, you might be able to be on the hard to execute side. If you have to show something tomorrow, you probably are more on that easy to execute side. So this, in a very simple format, is a way to begin some prioritization or down selecting on what ideas you might want to carry forward with in this particular section. You also need to do some sketching, again, for what that ultimate solution looks like. And again, what's that first low fidelity MVP? And that's what our solution sketch really helps with. And then finally, you have the business model canvas, which is the tool that Matt mentioned. And this is where the rubber really hits the road, because not every idea has a viable way with which it can become something real. And that usually rears its ugly head when you try to lay it out in much more detail using the business model canvas. And I'll give you an example of that in a minute. Next slide. So I'm going to share 3 specific examples, each of which showcase something different in this solution development stage. This is a particular project that the broader DoTank team was part of in conjunction with Comagine, where they were trying to address, we were trying to assess the challenge with vaccine hesitancy within nursing homes and how to arm providers to have a much more empowered conversation in that regard. And one of the tricks with this was this idea of truly understanding what type of tool could be useful in engaging in that conversation. So the team not only built a couple prototypes with what those different types of questions could be to engage around this discussion of vaccine hesitancies with patients and their families, they also mocked up a couple type of interfaces for how you could have something in front of you to help guide that discussion. They went back probably 5 or 6 times with those teams, getting ongoing feedback and feedback and feedback until we actually landed on what would be considered an MVP that could go out into nursing homes to be able to really be that very, very powerful tool to address vaccine hesitancy. And we were surprised every step of the way. Assumptions we had that we thought would be very important for what would go into a tool like that, either the questions or how that user experience would look. And we kept getting recorrected and reinformed for what the field really wanted. So that iteration was incredibly important. Next slide. The second example of a minimally viable product is actually one from Penn Medicine, which is now, gosh, more than a couple years old. But I had a chance to work with Roy Rosen, who at that time had been their chief innovation officer, who was very, very schooled in the innovation methodology that we've been talking about, and was an advocate of all advocates for MVPs. And so what they wanted to test before putting a broader orthopedics program into the market is whether or not anyone would come if they opened up a broader approach to same-day scheduling. So what they did is they basically put 2 billboards, literal billboards, in the Penn market. And it was actually the service line lead cell phone number that was the number to call. They put it up for a couple days. And on the bottom, you can see what they got. Over 3 days, they got 40 inquiries, turned into 29 appointments. And importantly for them, 46% of that was new to Penn. So what that did in that minimally viable product, it gave them enough confidence, there was demand there, that they could then beef this up into something better. Value was still given for those people that reach out. They got their ortho appointments scheduled, but they did it in a way that they didn't invest too much time, too much money before getting a sense that there was really a there. Next slide. The final example I'm going to provide is work that Matt and I did with the Providence Health System as part of, we had built their Innovation Academy for leaders at that director level and above for the Providence market in Portland. And all of the teams worked on different projects, and there was an aging in place, a senior care team. Almost every year we did this. And this for me is probably the best example of how the business model canvas really worked incredibly well. And so the team was working on what's this idea of what was the health system's role to play in building a senior peer network. The big idea that they came up with was like an Angie's List for elders. And they got behind it. They could think of all the ways. They had their business model canvas. They understood the customers, the value proposition. They understand how they would do the back end, but they couldn't figure out the revenue because they didn't want to advertise. They didn't want to charge people. They didn't think the health system would underwrite it outright. So even though it was a good idea, they couldn't figure out the sustainability model because none of the ways they thought about the economics felt good to them. So they took the idea, put it off to the side, and pulled another idea that they had around their senior peer network program and moved forward with that one instead. So when I say the rubber really hits the road with a business model canvas, you really have to understand the feasibility, the viability, and the desirability of these things you want to carry forward. And your business model canvas tool is an incredible way to do that. Next slide. And if you're a fan of Red Bull and it says Red Bull gives you wings, for me, it's that same idea with the business model canvas. You have all these great ideas that go in, you do this iteration, you learn, you put minimally viable things out there, but the ones that really make it to the next step that Adam's going to pick up the baton in a minute are only ones but have a business model around that feasibility, desirability, and viability linked to them, because that's important for both that first launch where you continue to learn, but it's incredibly important when you think about moving things to scale.
All right, so you've engaged your audience, you've understand their needs, you've empathized with them, they're part of the journey. You've done all the business modeling that Leslie talked about. You've built the fundamental story of how you're going to create, deliver, and capture value, right? All right, now it's time to launch and to spread the change and to disseminate it across your organization, right? So I'll share a few things, Adam. The next slide, this is where storytelling is critical, right? So on the next slide, I'll just share a few things. You've got to think more about just having good content here, guys. It's about your strategy for reaching the people that you want to influence. Remember, winning the hearts and minds of folks. So you've engaged some people, but not everyone, right? This might go to a much broader audience than have been involved in the design journey so far. So yep, you got to have that good content. You got to have the good story. It's got to be complete, right? You need to be aligned as a team in terms of you're not contradicting each other if you're part of the change team, right? Channels, you want to think about the different ways that you can reach folks. I mentioned this earlier. It can be through town halls, on your, common SharePoint, through email, whatever those avenues are. And plan is how you campaign to people over time. You don't get acceptance and understanding overnight. It takes multiple touch points. So really think deeply around this part. Next slide, Adam. And with when you're building the stories, if you want the content to be good, you have to appeal to the head, the heart, and the eyes. So you want to think about the data and the rationale that supports why this change is something that people should be interested in. The heart is the emotional connection. It can be quotes. How does it connect to mission? So you want to win that part. And the eyes is that, the aesthetics matter. So it's, how are you kind of crafting your messaging in a compelling and resonant way? And the next slide, you want to think about, and this is a really important one for me. As I mentioned, you don't change people's minds overnight. So you need to create experiences for people and take them on a change journey. So on the next slide, just talk kind of briefly. You can't just give people a recipe. So yeah, playbooks are important, right? You need to have things documented. Got it. You can't drop it on the desk and walk away. And you guys all know this. You've been on both sides of the coin, I'm sure. Can't just give them a recipe. You got to teach people how to cook. So if you're spreading, for example, and Adam will give a great example of this, a new process innovation, connect the source site. Who did the MVPs, right? That Leslie was talking about. Give them access to their peers to say, what did I learn? What have I done differently? To really manifest change, you need to create experiences for people. And it's not enough to just give them the rule book. So anyway, yeah, over to you, Adam.
Awesome. Thanks, Matt. Great tee up. And so, yeah, this last example for us, and I'll move through here so we can ensure we'll have some time for Q&A if folks are game for that. But this last example is all about teaching folks how to cook. And so what's cool about this one too, all the playbooks that I'm going to highlight, again, are available for download from our website, public facing. This was an oldie but a goodie. This was back when I was with the Illinois Health and Hospital Association. So DoTank was a client for me first for about 5 years. But I was with the Illinois Health and Hospital Association for over 11 years and left there as the AVP of Quality, Safety, and Health Policy. And in that position, I had the mandate of leading all of our state and federally funded quality improvement initiatives. So there may be some of you on the line who remember the old days of the HEN or the HIN, back when the ACA actually afforded us some resourcing to do public health and quality improvement work. We got a lot of great work done. And there was a high-level mandate from CMS for us, and this was within a partnership that we had between Illinois, Michigan, and Wisconsin called the Great Lakes Partners for Patients' Health. And the aim for us was to, as much as we could, identify, scale, and spread best practice. How do we ensure that hospitals across our state lines could lean into a process on C. diff or readmissions or sepsis or safety huddles and not have to reinvent the wheel? And we worked with DoTank through a very human-centered design process of a lot of opportunity validation, concept deployment, and then here value creation through this program that we called the Innovation Challenge. And so there was a few phases to this, but high level, what we did at the association level was we put out applications for a few of the biggest clinical topic areas that we saw opportunity for improvement in across the states of Illinois, Wisconsin, and Michigan. And we asked for applicants. we said, who are the hospitals out there that are demonstrating a hard and a soft ROI from a harms reduction and a lives save and a cost savings perspective on readmissions? For example, and we had a few different topic areas, and we identified these MVP sites from the other end, these most valuable player organizations who had processes in place that were just killer. And then we linked them up with mentor hospitals who were struggling in those areas. And what we did there over the course of about 6 months was teamed up high-performing organizations with orgs, again, that were struggling in a particular clinical area. And we identified the processes that those mentor sites had done, which drove the outcomes that we all wanted to see from a harm reduction, a cost reduction perspective. And we copy and pasted those to the other site. And so there was a lot of human-centered design. You can see some canvases here in the background. There was a lot of the work that we've talked about so far in this webinar that happened, but the magic and the value creation here was the end product of this whole process, which was a culmination of a series of clinical playbooks that are available on our website for download. And there's a few of them that I'll highlight here. This individualized care plan was an amazing one from a hospital outside of Chicago who spread and scaled their work to a 25-bed critical access hospital in Southern Illinois. We had a safety huddle best practice that we highlighted and an infection prevention testing review for C. diff. And you can see the high-level results and impact that we made here. But the thing about these playbooks, back to Matt's earlier pointer on storytelling and head, heart, and eyes, these weren't made to be crafted as 60-page dense ARC guides to reducing readmissions that was all black and white and that didn't really have the resourcing or how do we do it. It might have explained a process at a high level. So we wanted these to look and feel and read more like a comic book, and with the embedded resources of those teams who actually did the spread and scale. So it wasn't theory about these playbooks. It was identifying it, taking a few months with that mentor site, detailing the process, and then saying, okay, let's practice what we preach. Let's take this and copy and paste it into another hospital and then really learn about that process. And so it was after we did that work with the 2 mentor and mentee sites that we created these playbooks. So they're kind of field tested, if you will. And I'll go through just a very high level slides here. And again, you can download any of these playbooks, but we wanted to demonstrate most impactfully to CMS were obviously the outcomes and the impacts of these, but we wanted to get to the heart, for those of you that are quality improvement directors or clinicians out there, you want to hear the story of how something happened, not just in black and white, like, oh, that happened at a huge academic organization or at this big urban organization, and that sounds great for them, but how's that going to work for me? And so we really wanted to make these playbooks speak to the heart of the clinicians who adopted these processes and who scaled them in very different environments. Again, Dawn was 300 plus bed organization who took this process and scaled it to Jennifer's team at a 25-bed organization. And so as you go through these playbooks, what's really important, you can see the little arrows in the middle here under innovation. We frame the challenge and the opportunity, but then you can actually click on within these playbooks the resourcing that the organizations used to operationalize the work. So there's the impact, the hospital-wide DISH program is right there. And then we've got, commentary from both of the sites talking about barriers that they met or challenges that they faced or some of the successes that they had. And so these playbooks really, we kept that head, heart, and eyes concept at top of mind when we thought about value creation, because it was all about not just creating an awesome playbook that had evidence-based and that had all the resources here to do the work, but it was like, how can we create this in a way that will easily get adopted by other organizations who were not a part of this process at all? And that was the magic or the trick. And so the last thing I'll reference within these playbooks is this last page. Again, all these reference materials from the staff education processes, competency PowerPoints, EHR screenshots, Excel sheets, Word documents, the algorithms, all that stuff's baked in there. So instead of being a theoretical playbook of how you should be able to operationalize a concept, it's that plus all of your scaffolding to get there. And this looked really messy, right? As we worked with those teams for months, it was a plethora of different canvases, a lot of these that you've seen, but I'll highlight two canvases that are also embedded at the back of the playbook that we felt like were really critical in getting to that value creation. And there's good information on how to operationalize this canvas within the playbook, but the vision canvas is always a great place to start early on with teams, centering the why or the aim of what you want to do, outlining those desired outcomes of where you want to go, and then outlining the bold steps that might have to happen along with the needs and challenges that you might face along the way. And the last canvas that every team used super effectively, and this is a great canvas for any QI, PI teams that creates visually accountability and action. So the game plan canvas, at top, you can plat out a timeline. It could be 4 months, those chevrons. They could be quarters. You can break it down into 1 month, and they could be week by week, but it gives you a way to visually represent a timeline of where you want to go, centering what you want to do in that project, and then outlining all the nitty-gritty action steps that need to happen, along with the supports that you may need to accomplish these action steps and goals, and then who's a part of that team. So we use a lot of color coding on these. So Lydia, Caitlin, Logan, you each have a colored post-it note. Those are your action steps. And if used effectively, this game plan canvas can act as your agenda and your compass for a project, and is always one of the most satisfying canvases that we can use to create value for teams, because it's so simply coalescing a lot of ideas into one canvas. So I think that we've done a pretty effective job, Matt, at trying to get through a record-setting number of 70 plus slides in like 50-ish minutes. So let me kick it to you and see any parting comments that we might want to make before we kick it back to the AHA team and maybe have some Q&A.
So before sending it back to you, Jen, there are a few questions, and Adam, I think they're around quality improvement. So first one is from Julie around the Missouri project. How long ago was the Missouri project, and do you check in on the outcomes 6 months out, et cetera?
Yeah, love it. Great question, Julie. So we did our last community forum in September. So we spent the summer and early parts of fall in Missouri, and then we launched that report that I highlighted to the state in a webinar in October. And so we're meeting with Missouri actually this week to talk about next steps, and they're actually now putting together a maternal health steering committee that's going to oversee this work. So that's really like fresh and in process. But if it wasn't, yes, absolutely. And like the innovation challenge one that I just showed, that happened years ago. That was like pre-COVID work. And so critically important for us with our teams and our clients to kind of always go back and make sure that you're sense checking where you're at and where there's opportunity and where the progression is going.
And then Jen, if we can take one, I'll do one more if we can, and then we'll take it to you. So Rhonda asked, where does hospital quality improvement fall into playbook framework? Would they lead it with change management tools? I'll take a first stab at that and then kick it to you, Adam. So one thing that we use with change initiatives in any kind of system or organization is there's some amazing technology. So we use a proprietary software called Grapevine that we always calls a single source of truth to create those experiences for people to help with that change. So playbooks, video interviews. So there's a whole kind of collection of things to win the hearts and minds. And again, a single source of truth, curating that experience so people don't get lost and distracted and in 100 different systems is critical. So we use Grapevine for that, which has been really awesome. But Adam, you can build upon that, I think, from your QI perspective. So where does the quality improvement fall into playbook framework, and would they lead it with change management tools?
Yeah, so briefly, great question too, Rhonda. And this was, kind of the learned experience from being at the association for so long and heading up QI and knowing that if I went to Northwestern, they're a DMAIC shop. And if I worked with Memorial, they're all Lean Six Sigma. And knowing that there's all these different approaches to change management and QI, but the one that we have really embraced at DoTank and that I always embraced was the model for improvement that IHI embraces, knowing that that's kind of the core foundation of any QI work. And so from a framework perspective, we use the model for improvement and small tests of change to do much of this work. We're constantly chartering with teams to identify what their aim statement or what's the aim we're going to do, How are we going to measure our success? What are the handful of action steps or action items that we need to take and put small tests of change around? So the change management tool from that perspective, it's a lot of PDSing, it's a lot of chartering, aligning on aim statements, and then meeting with teams frequently to kind of guide those PDSA cycles and pick the ones that are working, right? And the ones that we're seeing momentum, energy behind, and that are showcasing outcomes. And then integrating those change ideas into that concept development and value creation pieces. That's the high level quick answer to that, but great question. Wish we could spend 30 minutes on that one, Rhonda.
Over to you, Jen. I think next slide, Adam.
Yeah.
You got-
Yeah,
Awesome.
let me do next slide. I'm slide
Thanks,
guy.
guys. I really appreciate
There we
it.
go.
And just to double down, I visit the Innovation Hub on your website fairly regularly when I'm looking for a certain canvas or inspiration to do something with my team. We use it all the time. And so again, we'll use it in person live with like the flip chart size canvases. We'll do things virtually with the digital canvas that will stick on like Mural when we're all remote. So again, it's been a huge tool, not only in our TeamSTEPPS courses that make them effective, but just as an effective team working at the AHA. So thanks for that deep dive into what human-centered design has to offer. Really appreciate it. So for those that are still with us on this call, please complete the evaluation form that appears on your screen after you sign out of Zoom. We really appreciate your feedback. And again, should you wish to claim continuing education credit, please create a Duke OneLink account if you've not done so before. But ultimately what you're going to need to do once you have an account, it's a one-time only setup, is to text the code you see there in red to the number you see on your screen within 24 hours. So that's how you claim your credit. But again, I just want to thank Matt, Leslie, and Adam for their time here today. They've been wonderful partners of ours over the years, and we really appreciate them. So thanks everyone for joining us. I hope everyone has a good rest of your day.